Hello, everyone, and welcome to another edition of Fit RX. I'm your host, Dr. Greg Dennis, and always love it when I have other physicians on my show. My guest today is Dr. Richard Malish, MD, and he has a pretty extensive background. I'll let him talk about that a little bit more, but he is a general practitioner, but has been in the Army uh, as a clinician and served in the special forces, and sounds like done a lot more exciting things in his life than I have. But he has written a book called Longevity for the Lazy. And I love the title because obviously, if you listen to the show, you know I'm all about longevity, but I feel like sometimes it can get confusing for people because, they don't know what to eat. And there's all these supplements that are out there and people get confused on what supplements they should take. And so I love it that this is almost like a longevity 101. So again, I love the title. And so we're just going to talk about what he does and talk about his book. And I'm looking forward to the conversation. So, Dr. Malish, thanks for being on the show.
No, thank you, Dr. Dennis, for inviting me. It's a pleasure to be here, and I look forward to talking about longevity for sure
Yeah.
with you.
Well, tell us, if you will, just a little bit more about you, a little bit about your background. I know you've done a lot of stuff in the Army, just
Yeah.
retired with them, but that a little bit about your career, but then also, how you initially got interested in longevity.
Yeah, thank you for setting me up for that. Yeah, I've been in the Army for 32 years, and I just retired in June of last year. So all of my time in medicine has been in the Army. And I went to the military medical school, which is in Bethesda, Maryland, and I started as a general practitioner. I served as a battalion surgeon, which is a primary care officer with a formation of about 300 soldiers, special forces operators. So I did that for a time, and then I went on to internal medicine, and then I came back and then again did primary care and took care of, again, a population of soldiers as basically their chief medical officer, the advisor to the commander on all things medical. So again, in that role, I'm taking care of a large population of people. And so that's where my interest in public health began and how to keep that force or formation ready to do their job, keep them healthy, and keep them at their peak of their healthiness. So I did that for several years, and then I did a fellowship in cardiology and really started to learn about cardiovascular disease and its impact on the population. And then I practiced cardiology for a few years. And in this role, I was really just taking care of individuals, but I had the mindset of a public health provider in the back of my mind. And then I just had some interesting experiences in which I took care of larger and larger formations of soldiers. So at one point, I was the division surgeon for the 3rd Infantry Division. That's about 24,000 soldiers, taking care of them. And again, looking at ways to maintain their health and prevent any sort of unexpected outcomes with them. And then at the end of my career, not exactly the end, but I was the hospital commander and director of healthcare services for the Fort Hood base, the Fort Hood installation. And so again, there I'm taking care of a large amount of people. And in all these roles, I've been focused on. I think you're a fan of this, Dr. Dennis, but making not treating illness if it can be prevented, but first and foremost, ensuring health through various mechanisms. And so those are the experiences that sort of created me. But I would say there was um, it's a combination of knowing cardiovascular disease quite well and seeing some bad outcomes, unfortunate outcomes in young people. And then my study of population health and public health that led me to believe that I could make a difference by writing the book that I did.
Hmm. Okay, very nice. I'm curious, just with your background, I've been here in the Midwest practicing where, obesity, especially in Oklahoma, is one of the highest in the nation. And, people are pretty dang unhealthy. I mean, all over, but especially here in the Midwest. I would think in the military, you're going to see overall healthier people than the general population is, or I may be way off. I don't know. Is that true? Or
That is true. Yeah, we tend to be less obese, but there's still bad habits and risk factors within the population. And then, the retiree population, which the military also takes care of, does then succumb to some of those, um, temptations. And we do have a obese population as they get older and become higher and higher at risk. So yes, you're right in that the active duty population tends to be in general healthier than the general population, but then our retiree population sort of regresses to what we see in the population at large.
yeah, gotcha. Um, so your interest in longevity really sounds like just stems from a kind of a public health standpoint, in making people healthier, right? I mean,
Yeah, I think so. I think that as a military physician, that's basically what we do. I mean, there's basically three things to being a military physician in my mind. One is taking care of trauma on the battlefield. Two is primary care for a generally healthy population. And the third is readiness and making sure that people function at the highest level of health that we can get them to. So I think it aligns well with those sort of subject matter experts that spend a lot of time looking at prevention, public health, and longevity. It's very similar to that, and that's why I felt that I had the experience to write a book about it. And a lot of it really comes from noticing that there was a gap in understanding the importance of prevention and the tools that are available to us at this point in history from some of my patients, especially as I got into being practicing individual cardiology, which again, I did in the middle of my career. But I began to understand that there was a gap in what providers know, the medical knowledge that we have about what it takes to stay well for long periods of life, and that what the general population um, knows and feels, and bridging that gap is something that's difficult to do typically in a half an hour, an hour, even an hour patient encounter. And so I wrote the book to help with that conversation.
yeah,
Greg, you mentioned the title, which is laziness, and I I believe that, and laziness kind of has a bad connotation, but as a species, we are a lazy species. It's not meant to be derogatory or negative. It's meant to be objective. We are a species that, for our weight, and I talk about this in our book, um, compared to other mammals of our weight, we're about half as active as they are. And there are benefits to not being active, to being slow, or to having slow metabolisms. Those species with the slower metabolisms live longer. And they have longer lifespans. And through the arc of history, they have survived for longer and longer than more active species. So it's it's not something negative. It just is what it is. As a species, compared to other animal species like us of similar weight, and other mammals like us, other than primates. Primates are lazy as well. But it's just something, it's hard. It's hard for us to overcome those built-in influences, drives, instincts to be lazy. And so uh, I wanted to accept that up front as a condition of being alive and not try to um, encourage or idealize lifestyles that are really difficult to achieve and maintain for most people, just because our nature doesn't set us up for it.
yeah, gotcha. Okay. Well, let's get into the book a little bit then. Longevity for the Lazy. I'm just going to start at the beginning, and you kind of identify our enemies. So, which makes sense. We have to know what the enemies are. So, talk about that a little bit.
Yeah, I think that yeah, and thank you for bringing that up. So one thing about the book that you know, Greg, is that I I'm a physician, a cardiologist, primary care, public health, and all that. But I'm also the subject of a professional military education. So it's easy for me to use the one sort of foundation and apply it to the other. So there's two major things, as you know, in our current time and place that kill Americans. Um, it wasn't always that way, but here, as we sit in 2025, um, between you and me, Greg, one of us will die of cancer and or cardiovascular disease, atherosclerosis, or some um, version of it. So it could be a stroke, it could be a heart attack, it could be heart failure, et cetera, but some end state that started from atherosclerosis. So those are the two things that kill one out of every two Americans. Um, and so we should be, in my opinion, very aggressive with preventing that, those two things. And because they have such a high prevalence, it affects so many people, our medical society has done a lot to find answers for them. We have good mechanisms for treating heart disease, but we have even better at preventing heart disease. And the same is true really for the common cancers that affect Americans. So we're getting better and better at screening for the common cancers that affect Americans. And so I think that it's a smart idea to identify those two things, classify them as enemies, and go and um, ensure through what I call offensive measures that they don't get us. Because again, if they're going to get it's going to be one out of every two, and we should eliminate that as the cause of death. If we do, then we'll go on, live a little bit longer, and encounter some other sort of end of life disease of the elderly. And that's what we want to do. We want to take out the common causes of death in America. And again, we have lots and lots of tools to prevent cardiovascular disease, to identify risk for cardiovascular disease and stop it. And we do for cancers as well. My concern is that, and I've had these conversations with people, there's this reluctance to take the medications, specifically with cardiovascular disease. When you've identified the risk factors, there is a real reluctance in our society to take medicines. Not so much with cancer screening, but there's really problems with gaps in screening for common cancers in our population as well, even in the military population, in our retirees, in which all that is provided to them. Cancer screening, for example, is provided as part of their health plans. We're never close to 75 or 80% in there in terms of getting these patients screened. And so there's a real, in my opinion, there's a reluctance or an ambivalence to doing what people need to do to prevent cardiovascular, these two enemies, preventing cardiovascular disease and then screening with all these marvelous, technological wonders that are out there to prevent cancer. So, yeah,
I
yeah, go ahead.
Yeah, no, I was just going to ask. So, I feel like we have a lot of good screening tools for cancer, obviously, and cardiovascular disease. I don't feel like there's much incentive as a primary care doctor myself for the prevention of those and the real prevention. So I'll use cancer as an example. I mean, I have a loved one with cancer, so I've studied a lot about that in the last year or so. And, I really believe that most cancers stem from metabolic dysfunction, as a lot of chronic diseases do. And the majority of the population is insulin resistant, has metabolic dysfunction, and it doesn't help that, we eat all the processed foods and, all the stuff that just kind of adds fuel to the fire. But we never hear anything about that, and especially on the primary care level about treating it from that perspective and before it ever gets there. What's your thoughts on that? Do you see that ever changing?
No, unfortunately, I don't, because Well, let me take that back. It can change, Dr. Dennis. I think it can change. It's going to require, generations, in my opinion, to change. So, um, it brings up the smoking analogy, and really population health in general. So, as you know, we identified smoking as a problem which led to cancer and heart disease, back in the 60s and 50s, and it's taken us, 50 years now to get it to to make it less of a population problem. I think, when our parents were alive, or if they're still alive, when they were in their prime, one and two, or, something like that, it was very, very common to smoke. Now it's less, it's like one in 10. But that required a generational change, and it required society to put into place several measures that took some time to happen, took some time to take their to produce the results that we have now. I think it's been huge. I think the fact that we've been able to reduce smoking as a population has been huge, but it took a long period of time. So, like when I hear people concerned about this processed food and the unhealthiness in food and the high calories in sodas and things like that, um, I don't think. I think people are educated about it, and I think it's not a problem of knowing perhaps that those things are bad for your health. I think it's more a problem of motivation, of avoiding those things specifically on a day-to-day basis. And until we, as a population, sort of eliminate that through public health measures, which are going to take time because they won't be popular. Um, there will continue to be those risk factors. But again, that's where my book uh, tries to, take that sort of. I think those sorts of things that you're describing are ideal, to avoid processed food, to avoid fast food, to avoid these things we know make us unhealthy. There are therapeutic lifestyle changes. I just think that it's very hard for that to be done on a sustainable level for most Americans. And again, some of it has to do with the environment we're in. It's easy to get, the fast food, et cetera. And much of it has to do, again, with our basic genetic structure. In other words, we are built to crave high caloric foods, I believe. And so we're going to have to change that. And it's very, very, in my opinion, difficult to do on an individual basis, and it will take generations to do on a population basis. My thing is, you can try to motivate populations away from that, but that to me is not low hanging fruit. Um, that should be done. It's very, very hard, and it's what I would call a it would be high impact but high effort. And so what the book really looks to do is find the high impact, low effort things that can be done, which don't require those deals, that amount of motivation to get to. So there's low hanging fruit. And for me, it's not changing your lifestyle so that you don't eat fast food. That's ideal. And no good doctor would say that shouldn't be pursued. I believe as strongly as you do that we should eat the green leafy vegetables, eat well. Um, it's just that I know that that's very, very hard for most people to do. And so I just sort of take that off the table and say, I see you for that. I understand that's something that you should do, but I'm not going to jump on the bandwagon and get behind that. If you can only do one thing, make sure that you're screened for all of those cancers that are deadly, but if caught early enough, and we know, through all these population studies what they are and when we should be screened, just don't avoid doing that. Just don't miss the low hanging fruit because there's very little cost to that. It's not about it changing your lifestyle. It's just about going to your doctor and saying, hey, I think I'm at risk for colon cancer, or just telling your doctor, hey, what are my age-related cancer screens that I should get and get those, whether it be colonoscopy. If you smoke cigarettes, I don't know that many people know that there's good screening for lung cancer now, which is the number one cause of cancer death in America. Um, but that's what the longevity for the lazy book sort of emphasizes. I accept that exercising every day, getting 10,000 steps is difficult. It's not that I don't want people to do that. I just don't want them to miss those technological wonders and great medical advancements that we all have now at our fingertips. That many Americans are not doing, or if you have cardiac risk factors, to get those under control using the appropriate dosage of medications. You'll see, in the book, I research it, but it's maybe 1 in 4 people that are at risk for cardiovascular disease that are taking the medications, which is a low cost intervention to get their cholesterol in the proper range to ensure longevity. So that's my thought on that. I know I've gone on,
No, no, you're
Greg,
good.
for a bit about that. Yeah.
Well, kind of on that, I mean, you have a chapter. I'm jumping around a little bit here, but
Yeah.
you have a chapter on specifically a plan for longevity, as far as you say, how to kill our killers. And so, talk a little bit more about that. I guess specifically, you're talking about the cardiovascular disease and cancer. So, um, what is our
Yeah.
plan to kill them or prevent them? I mean, you mentioned a little bit about medications, but what else can we do?
Yeah, so I'll start with cardiovascular because we're farther along with eliminating cardiovascular disease as a common killer in America than we are with cancer. But cancer is coming behind it, and there's reasons for that I discuss in the book. But cardiovascular disease, again, it's atherosclerotic plaques that develop in your blood vessels, and public health aims to prevent that from ever happening. Um, we have treatments, but it would be better if our population at large prevented that. And because of this Framingham study, which I don't need to go into with you, but we know risk factors that occur before plaque starts growing in our blood vessels. These are things that put us at risk, and if they're not treated early, then we tend as a population, maybe not as individuals, but as populations, to develop these plaques. So these are common things that everybody knows, and it's managing your cholesterol, not smoking, it's managing your blood pressure, et cetera. Um, so my point is, if you find that you have any risk factor, if you're anywhere outside of range, we have these marvelous drugs that our parents didn't have that are available to us at this time in the arc of human history, that should be taken. Again, many people, they don't. And I talk about why I think the reasons are for that. But I think that before you're sick with what you have a heart disease, you should be managing your risk factors very, very aggressively. And again, it's not hard if you embrace the current technology that we have. So I would say that, many, I'm not sure how old you are, Greg, but many people my age, many need to be on blood pressure medication. Many need to be on cholesterol medication. Many need to be doing studies that help them understand whether any plaque is developing within any of their vessels. So this is all preventative. This is occurring before you have some kind of mortality moment where you find out that you have large plaques in your blood vessels that you have been growing there hidden all along. You need to do this. You need to prevent these things as soon as you're in a risk range. And so that would require you to go to your doctor and say, hey, what's my blood pressure? What's my cholesterol? And the reason it's important is because this is a major killer of Americans. And then for for cancers, there is really not, we don't have the preventive measures that we have for cardiovascular disease. I don't know of anything that prevents cancer, to be quite honest. I know a healthy lifestyle, of course, but I don't know of a risk factor that you can target outside of smoking, perhaps, and say, like cholesterol, we know the lower we get it, and blood pressure, the lower we get it, the better off you are in terms of not having that heart attack when you're 60s, 70s. And living into your 80s and 90s. Cancer, not so much. So we don't have public health mechanisms to prevent cancer, but we do have, this amazing technology that wasn't available to our grandparents and our parents, which is this wonderful screening techniques that are there and available for anybody at risk for these high prevalence cancers. Any cancer that kills a large amount of patients in America, there is screening for, and there's a lot of data that supports it. So there's screening for, I mentioned lung cancer. We have new screening technology for that. For you and me, prostate cancer is an issue. For our wives and our sisters, we have breast cancer. All of these things have better and better screening. And again, there are, of course, many people that know to embrace these screening technologies, and they get their cancers caught early and they get eliminated. But many Americans don't. So these are low-hanging fruit, in my opinion, that, it's not that I don't want everybody eating well and exercising and all like that. I just don't want them to not embrace this new technology that it's verifiably causing us to live longer. And we can talk about that, but 100 years ago, 125 years ago, people died of infectious disease. But technology, the discovery of antibiotics and vaccines and everything, made the lifespan go from 47, which it was back in 1900, and that was normal for them. They thought if you had a heart attack at 60, you were lucky and you lived and you died of something of old age. Now we're living to 78, and my contention is that was through these developments, these medical developments and advancements. First and foremost, I don't think we became healthier as a population in terms of exercising more and eating more healthy. And so, again, I think if we don't embrace the technology that's out there, and we choose to perhaps, pursue these more high cost interventions, and again, I'll talk about diet, exercise, cutting calories, restricting calories, fasting, and all that. It's not that it's not good. It's just not as good and low cost as taking the medications that are there for cardiovascular disease and employing the cancer prevention techniques. So,
Just to, I guess, kind of play devil's advocate, because I can just hear my patients saying, well, wouldn't it be better to treat the underlying problem, rather than just putting a band-aid on it with the medication? Whether we're talking about high blood pressure, high cholesterol or whatever. And so I'll give the example of like metabolic health again. I mean, I feel like that's kind of the root cause of a lot of, cardiovascular diseases. And um, we could probably have a whole discussion about cholesterol.
mhm.
I don't know if I'm as sold as, the importance of cholesterol as you are. It's obviously important, but I feel like metabolic health is more important. There was a meta-analysis done that people that were metabolically healthy, and who had high LDL cholesterol, it was inconsequential. And so I feel like it's sometimes we're missing the forest from the trees. And that's what I try to do, is go that kind of step beyond of, okay, let's treat your insulin resistance. Let's get you metabolically healthy. Let's maintain muscle for your overall metabolic
Yeah.
health. Uh, and if we want to do some of these other things, okay. But I feel like we'll get more bang for our buck and kind of treating the underlying problem rather than, just putting them on medication or whatever.
Yeah.
I don't know, thoughts.
Well, that's why I'm glad that there are people like you out there, Greg, because don't get me wrong, I agree with you. I,
And
I
I agree.
think,
I agree. It's difficult. I mean,
yeah,
it's a big mountain to climb. There's no doubt about that.
yeah, yeah. I guess, again, my experience has been, it sounds like you have motivated patients, which is a blessing. And I'm glad that you have the time to get them to be, and they're educated and you're teaching them the importance of all these things. Um, as a cardiologist, what I have found um, is, people, I'll let them know that they have the metabolic syndrome, or they need to lose weight, they need to eat better. Um, and I'll say we could either, we could start these medications, or you could pursue therapeutic lifestyle changes. Um, and I just haven't had the success that you've had, Greg, with them really turning their lives around. And the data really supports that, that you can achieve, and we can have the debate, and I'm glad to have it with you. But the data that I've seen doesn't support the superiority of therapeutic lifestyle changes versus medications to reduce blood pressure, for example. If you compare the DASH diet, for example, to any one of a number of antihypertensives, there's been tons of studies that have done this. The risk is more consistently reduced with medications. And this is population health. I'm not talking about individuals. Anything can happen with an
Sure.
individual,
Yeah. Yeah.
but with populations, you get more reduction in that particular risk factor with medication over therapeutic lifestyle changes. And the same is true for cholesterol, and almost any quantifiable risk factor. You get stronger reduction in these surrogate markers for mortality, these things that we've been talking about, risk factors, but also there's a mortality benefit. So they always, we have the conversation, and I say, well, I wish you luck with that. But if we're unable to get you to where you need to go, then we have these strong medications that are available that you will take like a vitamin. There are very, very few side effects to almost any of these medications. And if there are side effects, there's, of course, different things that you can do to mitigate them. There's very low cost, is what I'm saying, to medications. And not there's cost to them in terms of money, but they're very low cost even in terms of monetary. But there's low cost in taking them. You don't require a lot of motivation to change. And in populations, they do better. But maybe I can have a conversation with you, Greg. In the book, I talk about the study that was done in Denmark. I don't know if you remember it, but it was a survey study, and it asked a population of about 1,000 people. And the question was, if you could get the same reduction in your mortality risk from taking one pill a day versus making your diet more low in fat and exercising an additional 30 minutes a day and cutting out smoking if you're a smoker, what would you do? And they didn't mention the cost of the medication. That's sort of like not a variable. You get a pill every day, and they mention no side effects to the pill. So you get the same risk reduction by taking a pill. They call it a medication, as you do from these therapeutic lifestyle changes. 30 minutes more of exercise, eliminating fat from your diet, and stopping smoking if you can. 90% of the people that responded to that said, well, I'd rather do the lifestyle changes. And that indicates to me that there's some bias there's strong bias against taking the pill, because the pill had no cost associated with it. The pill they didn't say this was $10 for a pill per day. They didn't say there were side effects to it. The benefit was the same no matter what you did. And yet the population, more than 90%, said, I'd rather do this thing. I'd rather pay a higher cost in terms of my lifestyle and reducing the things that I currently do. I would rather acquire that benefit at a higher cost than I would for no cost. So to me, there's a bias against medication. And I mentioned it's Denmark, and you might come back and say, well, that's a unique population, but they're a first world country, very, very similar to us in terms of, socioeconomic status. And that really mirrors what I've seen in my population as well. For some reason, we're reluctant to take, grasp and exploit these very, very strong preventive measures. And I think if we called them something different than medicine, if we said these are supplements or this is vitamins, that we might have a better, it might be easier for people to grasp and take and want to take. Um, but there is just a strong bias towards grasping what's right there for us. And again, I know it's artificial, perhaps. You might look at it that way. Um, but it wasn't available to our parents. And because it is, our population, you and I are, our population will live a lot longer than they will, except for those that for some reason their bias against medication decide to go it alone, I guess. I mean, so I don't know. What are your thoughts on that?
Yeah, I mean, I'm not familiar with that study. I'm surprised because I feel like so many people are on medications,
Yeah,
and that they don't, they go to their doctor, they get a medication, and then I always tell people, then they get sent to a specialist, and then they get put on another medication, and then they kind of do the rounds, and they're on all these medications, and
yeah,
then they come to me, and they're on a sack full of medications, and
yeah,
they're overweight, and they feel terrible, and I'm like, well, let's start getting you off these medications.
right.
Let's get you healthy. So, and I optimize their hormones, and uh, not all of them are motivated. I mean, they're not. Some of them would prefer to be on their sack of medications, but um, uh, again, that just kind of surprises me from patients that I've seen over the years, because most of them don't seem hesitant to get on medications, and
Yeah,
if their doctor prescribed medications, they don't usually ask too many questions, and
yeah.
they just take the medications. So
Yeah, no, that is a problem. I agree with you there. Especially as patients get older, there is a true problem with polypharmacy, and
yeah,
I lay it out in the book that there's a time and a place for medications, and as you get beyond the risk range for these medications, somebody like you or me needs to come in and say, okay, is there more harm than good that's being
yeah, for sure.
provided by this particular medicine? But my history is a little bit different, and that is um, I've seen a lot of young people uh, die from these common killers,
Hmm.
and it's because they have been ambivalent, maybe ambivalent's not the right word, uneducated about these risk factors that have existed within them because of their genetics or whatever. And they just haven't had the ability to sit down with somebody and go through it and have a really, good conversation to talk about it, whether it be therapeutic lifestyle changes or medication. I am always going to argue for uh, therapeutic lifestyle changes. I'm sorry,
Yeah,
medication. But then I would refer them to you to fix
yeah,
the
yeah,
other. Um,
sure. Yeah, yeah, yeah. Yeah, and I'm in a unique position because I used to work for corporate medicine and see 25, 30 people a day, and I got out of that because I started thinking differently like I do now, and I wasn't able to have these conversations with people and really get some lasting changes. And I would, oh, you have high cholesterol, okay, here's medicine, and oh, you have this, here's medicine, and
yeah,
there wasn't time for more discussion. And so now I'm in I don't know how much you looked, I'm in a cash based practice basically, so people pay me a monthly membership, and so I have a lot of time with patients, and
yeah,
so I can really hold their hand and walk them through these lifestyle changes, that I'm recommending, and sometimes it takes time, and again, still, even the people with me are not always motivated, but I've just found, if they are motivated, certainly better results than what I was able to give them, when I was in
yeah,
corporate medicine, and just giving them medications and not really being able to dive deep in the underlying,
yeah.
problems that are going on. So
Well, I think this is really important, and in the book, I talk about it. For me, and we're talking about it here. There's basically two important sort of conditions, and there's four ways of being within them. So there's the conditions of knowing and being compliant and adherent to what modern medical technologies are out there. So you could be completely up to date with all your risk factors, screen for cancer. That would be the best. And then there's being very, very motivated to do the things that you do with your patients, which is, I know you do everything, but exercise and restrict calories and these other things. So there's a spectrum of being knowledgeable and adherent with the modern medication. There's a spectrum of being I'd say lazy and motivated to go after therapeutic lifestyle changes. I think we would both agree that being in tune with modern medication and screening and whatever we've talked about, and being highly motivated to do therapeutic lifestyle changes is the best. The worst would be not to be motivated and to be ambivalent or uneducated or not know, or to be completely unprotected because you don't know any better with the medications. So being both motivated and attuned to medical is best. The worst is not having either of those. My contention is that if you can't be motivated and knowledgeable, it's more important to be knowledgeable than it is to be motivated. And I think where longevity books get off, start making things very, very overwhelming and complicated is when they don't recognize those sorts of categories, because you can go into a longevity book and it becomes overwhelming
Hmm.
because they go into everything. Whereas my book says, look, what this book is trying to do is not convince you that therapeutic lifestyle changes are hard, because I know that that is very, very high threshold to break through in order to do for most of us because of our lifestyles, everything else. I just don't want people not to be educated about what the current technology medications permit us to do. I think most longevity books say, okay, we're going to look at the population that's not knowledgeable and unmotivated, and we're going to try to make them both knowledgeable on medications and motivated. And I think that fails because it's overwhelming. Longevity for the lazy says, okay, I know that you're going to be unmotivated. All I really want you to try to do, with this book, and believe me, I talk about therapeutic lifestyle changes and how to get from point A to B, but I really want to emphasize the need to be knowledgeable and compliant and in tune and up to date with the things that are out there and not blow it off, because really there is a very big gap in what we know to be healthy as providers in terms of medications, risk factor management, and what our population is doing. And you might see a different population than what I do, but when I was working at these, taking care of these big formations of people, I was able to see the statistics and I can read the literature, and it's very few of us Americans that meet the guidelines for cholesterol management, all these risk factor management. So again, my book isn't trying for the home run, which would be to make people therapeutic and knowledgeable and motivated. It's accepting that most of us aren't motivated, and saying, okay, don't sleep then on these other things, because in my mind, through the arc of history, it's the medical advancements that have made us live longer and longer and longer, and will keep us living longer and longer into the future as our children grow older. They're going to live longer than we are. It's going to be because of the medical things that happen, not stricter adherence to lifestyle, healthiness, et cetera. And so that's kind of the goal of the book. But I think this discussion that we're having is at the core of it. You know, this dichotomy of things to pursue.
Yeah, yeah.
Yeah.
I full transparency. I mean, I'm not anti-medicine. I'm at all. My patients know that. I mean, there's certainly a place for medication, and I prescribe them all the time. But um, over the years and me studying this stuff, I have um, lost some faith, I guess, in conventional medicine, and I guess I've just been able to uncover a lot of things that, and I'll give an example like diabetes. I was never trained that you could completely reverse type 2 diabetes. I was never trained that you could reverse, in some cases, some autoimmune diseases.
Yeah,
And I've seen it, I've done. It's difficult, but and it's just, oh well, if you're diabetic, you give this medication, this medication. It's all about the blood sugar. And when the blood sugar gets too high on these medications, and you give them insulin, and I mean, it's all about controlling the blood sugar. And then they're admitted to the hospital and they're put on an ADA diet and they're giving them carbohydrates, 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 and then just more insulin. And it's just this
yeah,
vicious cycle. And then when I learned that you can actually reverse diabetes, and I'm like, why was I never taught that? And it goes
yeah,
back to there's 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 no motivation because there's so much money, in all that stuff, and
yeah,
that's a whole nother discussion. But anyway,
yeah,
I'm not, again, I'm not anti-medicine, and I'm not, minimizing the advancements in medicine, and we've certainly come a long ways, and many of those are great things. But I guess I'm just frustrated with the conventional medical system that it doesn't stress more of that we can it, it's all about medication, and not that, well, you can prevent and even reverse a lot of
yeah,
illnesses by
yeah.
lifestyle. And I guess I just wish that was there was more awareness about that.
Yeah, no, I think we see eye to eye there. And I appreciate what you're doing with this podcast and other things as well, Greg. And that is to combat, tell me if I'm wrong, but this illness-based healthcare industry
For sure.
that
Yeah.
we're in, and to get towards health and prevention. And there's a lot of things that are, I think your practice is great. And if there could be more people, if you could spread what you're doing around, and maybe it'll happen. Again,
I'm the
I talked
minority for sure.
um, it's it's to me, it's lowering risk in already moderate or low risk populations that have the biggest bang for the buck. And I go into that in the book. And it's those things, what you're doing with your population, that when it becomes normalized, and I talked about smoking earlier, so that everybody knows what you know, and it's occurring across the country, that we will have that sea change that you talked about earlier, where our populations, are healthier, and because we lower risk in moderate or low risk populations before anything bad happens, and prevent bad things from happening through education. Um, I'm just I think it's a long game to play for all the things that you mentioned.
Oh, no doubt.
I think they're trying, our government and our healthcare system is trying with value-based care and all this stuff, but it's not around the corner, in my opinion.
Yeah, no doubt.
Um,
Yeah.
so
Yeah. Uh, well, very quickly, and I don't know if you'll know this off the top of your head, but in uh, towards the end of the book, you have longevity for the lazy top 10. Do you know what those kind of top 10 things are off the top of your head?
Well, I don't, but what I would do, I can summarize what they are, and it's
Okay.
basically, it's what we've been talking about.
Okay.
It's go after those things that we know are going to get most of us. Go after them proactively and offensively. So find out what your risk factors are for a cardiovascular disease. If you don't, you're going to likely develop it. Either you or I will. One out of every two people will do it, and prevent it from happening before you have the disease, and do it very, very aggressively, and be offensive about it. By offensive, I mean target it, think about it, and go for it. And the same is true with cancer. And again, I don't know of any prevention that's there, but we have early detection, which is the next best thing that you can get to with public health. So detection and then elimination. So that's the first thing that what you're going to want to do. By doing that, we'll prevent the common killers of Americans, and that'll allow us to live longer to be exposed to some other disease of the elderly. And the more we do that as a population, the more prevalent that disease will become. And I'm thinking about cognitive decline and things like that, and then frailty. The more prevalent those things come, the more we'll direct all of medicine's attention towards those things, and at that point, we'll develop prevention for those. So that's that. So target those things that kill us, enable us to live to meet some other and end of life disease that's now affecting a minority of us. But if we prevent these diseases, it'll affect more. And then let us transition to those being the more prevalent things that we're going to eliminate as a society, as a species. Then I would say don't miss any low-hanging fruit. It's no cost. It's very low cost to take the medications. And I'm a believer in these. I mean, the evidence base behind the abilities of these medications is enormous. And they're low cost. You don't have to significantly change your life or whatever. Embrace those low-hanging fruit things that you can do. I had mentioned drinking coffee in the book as well. If you like drinking coffee, that's a good thing. Because that prevents a whole lot of other things. That's a supplement that we discovered somewhere along the road, but there's tremendous health benefits to that. But do the low-hanging fruit things first, the low-cost, high-yield things, and then work your way through to the high-cost, high-impact things. Work your way to that. I'm not saying don't do that, but don't sleep on the low-hanging fruit and get there through that. And so those are the major points. I talk about, what you do in your clinic is what I would call defensive measures. And so I also want people to be healthy until into their 80s, 90s, and 100s. And you do that by doing what you do, which are therapeutic lifestyle changes. That's defense. That's not targeting things. That's making your body stronger, less frail, more cognitively with it. I want all those things to happen too. I just acknowledge there's a little bit more cost and it's harder for most people to do. So I say eliminate, through low hanging fruit with all the ammunition you can, the common causes, and then do these defensive measures, everything that you do secondarily to make sure that when you get into your 90s and you're looking at cognitive decline, that you're prepared for that and so on and on. So that's what I would summarize as they're bulleted there, as you know, but that's the main take-home points from those longevity top 10.
Okay. Well, very nice. Well, this has been a good discussion. So again, the name of the book, Longevity for the Lazy. I know people can find that on Amazon. Are you on social media, or are there other ways that people can kind of follow you or?
Yeah, I'm on I'm on well, I don't know if this counts. Like I'm not on anything fancy. I'm on LinkedIn,
Okay.
and then I'm on Facebook, and I'm on X, formerly known as Twitter. All of those are things that I'm on.
Okay. Okay. All right. Well, as we wrap up here, I always ask my guest if they could give us one health tip that could make us healthier today. What would you say to that?
I would say, you know, I don't want to reiterate what we've talked about, but I guess I would say just know what your risk factors are for cancer and heart disease, and do the low hanging fruit to prevent those things from happening. That's all I would say.
Gotcha. Okay. Well, I was gonna kind of wrap up, but I just thought of a quick question I'd like to ask you.
Sure.
So there's the new Gallery screening test for cancer. I don't know how familiar you are with those. It's a blood test that checks for over 50 different types of cancers. Pretty accurate, but of course, insurance isn't covering those yet. They're pretty expensive, and just kind of being in the public health, sector, I just wondered, are you a fan of those, or have you researched them much?
I haven't done the research, so I don't really know the cost benefit analysis. I'm not against any of that. I just know that a lot of insurance plans don't cover them.
Right. Now, I don't think
Um,
any of them do right now. Yeah.
yeah, so I would say though that if your means allow for it, that it's probably a good investment The problem with, and I don't know about the gallery, but some of these tests are that they're sensitive and not specific, meaning that there's false positives, and
Correct.
then
Yeah.
that causes a lot
Yeah.
of
Anxiety.
heartache.
Yeah. Yeah.
Yeah,
Yeah.
so I'd have to research a little bit more, but I'm not opposed to using technology to get even more aggressive with screening for common cancers. I
Mhm.
think that um, that's all in line with sort of the themes that I presented so far.
Yeah. Perfect. Okay. Well, Dr. Richard Malish, appreciate your time, appreciate the discussion, and as always, appreciate everyone listening. And we will talk to you next time.
Thanks, Craig.